Thank you for joining us for the 5th Annual Global Summit on Kidney Innovations, If Not Us, Who? If Not Now, When? A collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Sharron Rouse. I'm a proud AAKP Ambassador and kidney transplant recipient. Like so many of you listening around the globe and the world today, I was unexpectedly diagnosed with kidney disease. To say that I was shocked is an understatement. After being diagnosed with focal segmental glomerular sclerosis, FSGS, and eventually starting dialysis, I decided on that fateful day to take an active role in my kidney care and to be the change that I wanted to see. As a result of my journey, I founded Kindness for Kidneys International, a nonprofit organization committed to educating, encouraging, and empowering kidney warriors and their families. Thanks to my sister in 2013, I received the gift of life, and I'm forever grateful for her. She's my hero and my angel. It is my honor to be here today at the 2023 AAKP Global Summit as an AAKP Ambassador. Being a part of AAKP since 2018 has allowed me to connect with kidney warriors around the world and to use my voice and my experiences in a meaningful way and to demand more innovation and choices for myself and others diagnosed with kidney disease. In 2019, AAKP announced two major initiatives, AAKP Global, and the Decade of the Kidney. AAKP is engaged internationally because we are committed to educating patients and leaders across the globe on the importance of kidney disease prevention, new innovations in treatment, and the necessity to save more lives. We believe that a united patient voice can drive innovation, and just as importantly, better align policy, regulation, and payment decisions so that patients can gain timely access to new life-saving therapies. Across the globe, we are working with patients, medical professionals, researchers, and medical industry allies to accelerate momentum to address the many unmet needs of the global kidney community. As you've heard this morning from AAKP President Ed Hickey and former HHS Secretary Alex Azar, an international patient collaboration can advance innovation and change kidney care. Patients, medical professionals, and private sector partners are already driving these changes and have much more to do within the US and other countries, where our healthcare systems and infrastructure do not support patient consumer choice or access to all treatments. I am pleased to be the moderator for today's session titled Innovations and Emerging Opportunities, Cardio-Renal Syndrome. First, welcome Dr. Nisha Bansal. Dr. Bansal is a professor and a holder of the Arthur Stach Family Endowed Professorship in Division of Nephrology at the University of Washington. She is also an investigator in the Kidney Research Institute, the director of nephrology Clinical and Research Education, and the director of the Kidney Heart Service at UW. Dr. Bansal's research program consists of clinical, patient-oriented studies to understand the pathophysiological diagnosis, the treatment of hypertension, cardiac arrhythmias, and heart failure in patients with chronic kidney disease and those treated with dialysis. She has published extensively in top journals, and her work has been cited in clinical practice guidelines. Please turn your attention towards the monitor as we welcome Dr. Bansal. We're so happy to have you, Dr. Bansal. Take it away.
Wow, thank you so much. It's such an honor to be here today virtually from the West Coast. And I want to thank Sharron for that really wonderful, powerful introduction. And thank you for all the work that you are doing to advance care for patients who live with kidney disease. So it's my pleasure today to present on innovations in cardiorenal disease. Could we please share my slides? Excellent. So today I'll be discussing innovations and emerging opportunities in cardiorenal syndrome. Next slide, please. So why do we care about cardiovascular disease in patients who have kidney disease. So we know that patients with kidney disease do have higher risk of poor clinical outcomes. Please advance, which include, unfortunately, loss of kidney function to where they have kidney failure and need dialysis. Next, please. But unfortunately, what we've seen from numerous studies is that, in fact, the death from cardiovascular disease causes outweighs this risk of progression of their kidney disease to kidney failure. And for that reason, it's incredibly important to understand why patients are developing cardiovascular disease and how we can treat them better. Next slide. And so this is a seminal study from, gosh, almost 20 years ago now, which demonstrated that level of kidney function actually is incredibly important in prognostication of cardiovascular risk. And so what this figure is showing along the x-axis is level of eGFR, and along the y-axis are rates of cardiovascular events. What we see is that as your kidney function declines and your GFR is lower, there's this very strong stepwise gradation in terms of increased risk of cardiovascular disease. Next slide. And so, what types of cardiovascular disease patients with kidney disease are developing is also important in terms of determining the best treatment approaches. So, this is a study that was led by my group where we looked at almost 18,000 persons who did and did not have kidney disease. We compared the rates of 3 different types of cardiovascular disease, including heart failure, coronary heart disease, and stroke. The persons who had kidney disease are represented by the light gray bars, and those without by the black bars. And what we see is that the rates of all 3 types of cardiovascular disease are substantially higher in those who have kidney disease compared to those who do not. And in fact, if you look at the height of the bars, as well as the difference in the height of the bars between those with and without kidney disease, we see that heart failure and coronary disease are really driving a lot of the cardiovascular risk that we're seeing in our patients. Next slide. And once a patient who has kidney disease develops cardiovascular disease, such as heart failure or coronary artery disease, we do see that they have increased risk of dying prematurely. Uh, Onset of cardiovascular disease also accelerates loss of kidney function subsequent to their diagnosis. Patients suffer from poor quality of life and also have frequent hospitalizations, therefore emphasizing the need for cardiovascular disease reduction in patients who have kidney disease. Next slide. So why are we seeing so much cardiovascular disease in our patients? So when we think about cardiovascular disease risk factors, there's certainly traditional risk factors, ones that we see regardless of kidney disease status, and those include older age, obesity, male gender, tobacco use, family history, hypertension, diabetes, and lipid disorders. And certainly patients who have kidney disease have higher frequency of all of these comorbid conditions, which place them at risk for cardiovascular disease. However, patients with kidney disease also have a number of specific risk factors that we see in the setting of kidney dysfunction. And those are demonstrated on the right here. And this is only a partial list, but they include toxic metabolites from retention of solutes that are normally cleared by the kidney, albuminuria, inflammation, oxidative stress, dysfunction of your blood vessels or endothelial dysfunctions, anemia, nutrition. We've heard about nutrition today, as well as bone mineral metabolism, so abnormal calcium, phosphorus, PTH, and vitamin D. And the collective result of this high burden of traditional risk factors, as well as these kidney specific risk factors, is that we have downstream remodeling or damage of the heart, as well as the blood vessels, which lead to cardiomyopathies, atherosclerosis, arterial stiffness, and calcification, and subsequently lead to these cardiovascular events such as coronary heart disease and heart failure. Next slide, please. And knowing this, we see that because the pathophysiology of cardiovascular disease is different in patients who have kidney disease, this requires different approaches to treatment. Next slide. And so I want to highlight two classes of medications which really have become blockbuster drugs, I would say, in the last several years. And we've heard about some of this from our last speaker in the last session, but those include non-steroidal MRAs and SGLT2 inhibitors. Next slide. So we know that different hormones, including aldosterone and cortisol, bind to this receptor called the mineralocorticoids receptor. And the binding of this receptor leads to many downstream organ effects of the blood vessels, the heart, the kidneys, and the brain, including endothelial dysfunction, fibrosis of the heart, damage to the kidneys, including causing electrolyte imbalances, as well as glomerular injury and effects on the renal blood vessels, as well as activation of hormonal pathways that lead to damage in the brain and the neurologic system. And for that reason, blockade of this particular receptor, the mineralocorticoid receptor, is an attractive target pharmacologically for preserving organ function. Next slide. And so traditionally, we've had a lot of experience, I would say, in using what are traditional mineralocorticoid receptor antagonists or blockers, including medications such as spironolactone. And medications in this class certainly do block this receptor, which helps organ dysfunction. However, some of the challenges with use of these steroidal MRAs are the lack of specificity, specifically in terms of the tissue distribution. We see that there is greater accumulation in the kidney versus the heart, and it's less specific in terms of its action on the receptor, and therefore can lead to adverse effects such as gynecomastia or growth of breast tissue. And so more, next please. And so we heard about the most recent trial that was just presented at the ADA in the last session, but I think we've learned a lot about this other class, this other alternative form of MRIs called non-steroidal MRIs, which include finerenone. And the benefits of this class of medications is enhanced selectivity for the mineralocorticoid receptor, which decreases some of the effects that we see in terms of the unwanted effects of the medications, and greater balance between the kidney and heart, leading to less electrolyte abnormalities. Next slide. And so this is a snapshot from one of the major trials, and we saw some more recent data as well. But this is from the Fidelio CKD trial, which randomized patients who had chronic kidney disease and diabetes who were already on a RAS inhibitor, such as an ACE or an ARB, and they were randomized to finerenone, which is our non-steroidal MRA, versus placebo. And this is looking at a cardiovascular endpoint. And what we see is that there is a difference between those two lines, leading to which represents about a 14% reduction in risk of cardiovascular events with use of finerenone. Next slide. The other big class of medications that we've seen have significant impact are SGLT2 inhibitors. And these also are what I would consider blockbuster drugs in treating chronic kidney disease, diabetes, as well as cardiovascular disease. And the way that these medications work is that they block receptors in the kidney in the proximal tubule called the SGLT2 receptor. And by blocking this, this leads to excretion of sodium as well as glucose in the urine. And excretion, this natriuresis and this osmotic diuresis has several kidney protective effects. By having distal delivery of sodium and glucose to the latter part of the nephron, we're restoring normal balance or tubular-glomerular feedback that happens in the kidney, which then leads to better pressures or transglomerular pressures through differences in direct actions on the blood vessels that go in and out of the kidney. And that works downstream to preserve kidney function as well as reduce proteinuria. In addition, the effects of these medications have also been shown to help with blood pressure, intravascular volume, And the culmination of this is that it does affect the heart as well. By improving blood pressure, for example, it decreases the workload of the heart, improving myocardial energetics. And then obviously the glucose lowering effect provides some additional benefit as well. So overall, these medications have been really successful in helping preserve kidney function as well as cardiac function. Next slide. And there's been just a whole host of really seminal trials in this space. And we've seen the greatest results and the most promising results in treating those who have CKD as well as those who have heart failure. And so numerous trials have shown demonstrated substantial benefit in these populations, and particularly when there's overlapping CKD and heart failure. Next slide. So great progress. I mean, I would say that it's been a really exciting time for patients as well as nephrologists to be in the space to see of all the exciting advances. But I urge us not to stop there. We still have lots of work to do. And so I'm going to outline some of the areas that I think that there is a need for more studies in the cardiorenal space. So first of all, thinking more about mechanisms of disease and cardiovascular disease. Some of the most recent studies have really focused on diabetic kidney disease, which is wonderful. It's one of the leading causes of kidney disease, as we all know. However, there is a need to understand how cardiovascular disease medications work in other etiologies of kidney disease. As we know, all kidney disease is not the same. I think we can be doing more in terms of thinking about precision medicine to really tailor our therapies, including cardiovascular medications, to get the right medications to the right patients at the right time. As I mentioned, the pathophysiology of cardiovascular disease is different in patients with kidney disease, and I think this deserves a further dive into treating kidney-specific risk factors for cardiovascular disease. And then, I think although we don't think of renal replacement or dialysis as similarly as medications per se, it is still a therapy. And so is there more progress we can be doing in that space to improve cardiovascular risk? Next slide, please. The other big space that I'd like us to think about collectively is, are we studying the right patients who have kidney disease? And this is an ongoing issue for all studies, including clinical trials, but I think we do need to think about increasing representation of persons from diverse backgrounds who have kidney disease in all studies, including those trials of cardiovascular disease agents. We need to do this by increasing our accessibility to clinical trials and thinking really hard about how we can remove barriers to participation where it becomes more person-centric and less of a burden. Next slide. And finally, it's not enough to find these new therapeutic approaches, but we have to get them to our patients. And so I think the field of implementation science, or getting advances to patients directly, is a growing space in nephrology that I'm particularly excited about. And I think there's a lot of approaches we can do to tackle this problem. We can utilize pragmatic study designs, which bring us a little bit closer to delivering therapies to the patient and to the bedside. Think more about implementation science trials when we are designing trials of new therapies. And then, of course, think about social determinants of health and how that would affect uptake or use of new therapies. Next slide. So to conclude, next, we've seen that there's substantial risk of cardiovascular disease in patients who have kidney disease, which are associated with poor outcomes. Next. Cardiovascular disease is different in CKD, so the treatment actually requires different approaches in our patients. Next slide. There's lots of exciting progress, I would say, in the last decade with all these new therapies, including non-steroidal MRAs and SGLT2 inhibitors, which is incredible. Next. However, I urge you there's more work to be done. This is just the beginning, so I look forward to seeing more studies in this space. Next, please. Thank you.
We appreciate you taking your time and to share your insight and your expertise with us. Thank you. Our next guest speaker is Dr. Gurusher Panjrath. Dr. Panjrath is an assistant professor with our allied partners at George Washington School of Medicine and Health Sciences, and serves as the director of the Heart Failure and Mechanical Support Program. He has a particular interest in patients with various forms of heart failure and cardiomyopathies. He evaluates patients for therapies such as left ventricle assist device and heart transplantation for those with advanced disease. Dr. Panjrath believes in fostering long-lasting partnerships with patients so they can have a better understanding and control over their health. He also believes that excellent relationships with community providers are crucial to optimal access for advanced therapies and care. He is truly an enthusiastic advocate for patients and their families. Please welcome Dr. Panjrath.
Thank you, Ms. Sharron Rouse. Again, I hope I got their name right. We were practicing our names together earlier. And it's a pleasure and honor to be here. I want to thank the AAKP and co-chairs, Dr. Raj and Mr. Conway, for this invitation. Again, it's a true pleasure to be here. So between the previous session and the previous speaker, I think my work is already done. So what I will try to do in the next 10 minutes or so, paint like with big, wide strokes, some of the advances in heart failure as it relates to kidney disease specifically. So while we're talking about advances and innovations, I thought it would be pertinent to show you AI-generated rendering of Pablo Picasso's version of cardio-renal interactions right on the main slide. So that's I guess the future is here, and hopefully it will help us in this. Let me just make sure. These are my disclosures. So when we talk about heart failure, why are we actually talking about heart failure in this forum? It's important because there's more than 1 million hospitalizations in the United States and Europe. And this is not a problem unique to either US or Europe alone. This is a worldwide problem. So there is significant morbidity and mortality attached with the heart failure state or disease condition. In fact, the mortality by any standards is worse than cancer. Also, there's, when we talk about hospitalization, a lot of these hospitalizations in this patient population actually happen in the chronic state due to decompensation rather than the de novo diagnosis period. I thought it would be pertinent to show you a journey of the heart failure patient, as you can see here. And it can be divided into different phases. The initial part is when the patient gets diagnosed with heart failure. And then there's a stabilization phase where a lot of the medical therapies kind of take place, or we do intensify them. And then subsequently towards the later part of the journey, there's frequent decompensations, repeat hospitalizations, and worsening quality of life. And then we move into advanced heart failure stages where some of the specific therapies are indicated. And finally, this leads to mortality in a significant amount of patients. So when we talk about the journey and advances, I think it would be pertinent to look at different aspects of the journey and what are the advances. So let's start with the early phase where there's a stabilization. There's a lot of advances which have been made in this phase. There's a lot of pharmacological advances. Some of it you have already heard in the last session and the previous speaker. But now in 2023, we have fantastic drugs. We have fantastic medications. We have 4 classes of medications which, when used along with each other in the appropriate way, in the appropriate populations, can render significant benefits, both in mortality as well as morbidity. As you can see on this slide, if the 4 classes of agents such as beta blockers, MRAs, or the mineral receptor antagonists, SGLT2 inhibitors, and ARNIs, which are angiotensin receptor neprilysin inhibitors, used in combination with each other, can provide significant reduction in hospitalization at 2 years as well as mortality in this patient population. So this really forms the backbone of heart failure pharmacology. We heard a lot about SGLT2 inhibitors. This is, again, a similar slide to what we saw in the previous talk. SGLT2 inhibitors have been now studied across various populations in the continuum of the cardio-renal space. Patients with diabetes, with and without kidney disease with and without heart failure, and kidney disease with and without diabetes as well. And across the board, you can paint it with, again, a kind of a broad brush, and the benefits are immense. There's improvement in heart failure mortality, as well as heart failure hospitalization and cardiovascular mortality in different populations, and this is substantial. Well, what's beyond that? Beyond the 4 classes of medication, there's a lot more. There's improvement or now availability of medications such as vericiguat, which is a soluble guanylate cyclase inhibitor, more patients which are advanced heart failure towards the later part of the journey. There is omecamtiv mecarbil. Now, this is a drug has not been FDA approved in the United States as of now, but the results were very powerful, and hopefully we'll make some progress on that. And then there are other therapies which are listed there on the right column. What this has allowed now in the heart failure space to tailor our therapies. We heard about clinical phenotyping in the previous talk to tailor our medicine, precision medications. And this is a form of precision medicine now. We can, based on the presence and absence of CKD, diabetes mellitus, arrhythmias, we can now tailor different classes of medications, different populations to provide them with greater results. What about beyond pharmacological agents? Now we are in a space where we have advances in both procedural as well as device therapies, and these are device therapies still in the early stages. We'll talk about later stages later on. This is procedures such as mitral valve repair, which is a commonly seen problem in heart failure patients. Emerging therapies such as cardiac contractile modulation and barostimulation, and out of them, specifically barostimulation, I do feel with the underlying pathophysiology may have a role to play in the cardio-renal space. Pulmonary vein isolation in those with atrial fibrillation, which becomes a significant problem and adds morbidity to this population. And then pulmonary artery monitoring, which also goes by the name of CardioMEMS device, which allows for hemodynamic monitoring of patients, remote monitoring, and this allows for titration of medication, especially diuretics, and other therapies which can also portend benefit in the cardio-renal space as well. Moving on to the latter part of the journey, this is at the advanced heart failure state where patients have frequent decompensation, worsening quality of life, and this is where advanced therapies such as left ventricular assist device as well as cardiac transplant play an important role. And let's see some of the advances in the LVAD space. Now, LVAD journey started around 2000, and by 2023, we have different generations of devices. As you can see on the right side of the slide, the devices have become smaller, easier to implant, better outcomes. We are reaching an outcome of 83% or 84% survival at 1 year, and the recently presented data in NEJM shows 5-year survival around 58%. That's substantial. This was a population which was non-transplant eligible. So this is what we call is destination therapy. These are patients who could not meet criteria for transplant, and they were in end-stage heart failure. They got these devices, and they're living, 58% of them are alive at 5 years. So that's really, allowing patients new therapies to keep them alive and improvement in quality of life. Now, talking about transplant, there have been a lot of advances in transplant as well. As you can see, there's expanded donor pool now with organs such as hepatitis C, viremic organs available which have expanded our pool of organs which we can harvest from. There have been improvements in immunosuppressive therapies. There's also major advances in surveillance of rejection in these organs using cell-free DNA and as well as image analysis as well. So all these things are allowing now better outcomes, expanded access. On top of this, we have DCD donor pool, which is coming up in the United States with high speed, as well as donor preservation or organ preservation techniques, which will allow for greater access and even using organs which were traditionally discarded, now accessible for patients. So because just for reference, because that's kind of one of the biggest limitation in cardiac transplant is organ availability, when we have a big wait list of patients and we don't have enough organs available. There are a lot of other advances, which I'm not going to talk about, things such as xenotransplant, which was in the news last year, a major step forward, but a lot of work to be done. So I think it doesn't fall into the for this particular stage. And then things which, again, we heard in the previous speaker, equitable access. How do we improve our equity of access to our patients for these advanced therapies? Now, after all, this is a kidney conference, so I have to talk more about cardio-renal space specifically with a heart failure focus. So, for those who are not familiar with cardio-renal syndrome to me kind of falls into three categories. One is heart failure resulting in kidney disease. Second category would be kidney disease resulting in heart failure. And the last category is systemic disorders such as amyloidosis and others causing both heart failure and kidney disease. And this space has a lot of advances, but to understand those, let's kind of briefly look at the pathophysiology, and I'm not going to go too much delve into detailed nature of time, but there are issues such as congestion, decreased perfusion to the kidneys, decreased lymphatic drainage. So all of them add to different aspects of cardio-renal syndrome, and there are a lot of new development in this space coming up. Before that, again, just a quick mention on finerenone, which is a non-steroidal MRA, which we have heard twice over now, but to kind of emphasize the same things which we have heard before, have made major progress in terms of cardiovascular and kidney outcomes in type 2 diabetic patients and kidney disease patients. Ongoing trials in the heart failure space, so there's excitement there. Hopefully, there will be positive, more to come on that. Now, what does cardio-renal syndrome or the space look like in the future? There are different therapies directed towards some of the underlying pathophysiological underpinnings of CRS. And these are things which may either remove fluid or remove congestion, could be in the form of ultrafiltration or specific peritoneal dialysis, which may be independent of kidney function, so help relieve that congestion. It could be increased perfusion to the kidneys, which could be what I would call different kinds of pumps or pullers, and we'll see that in the next slide. And then devices which may help with increasing lymphatic drainage, which also helps with the cardio-renal syndrome as well. This is just a schematic of some of the newer devices, such as splanchnic nerve stimulation, as well as some of those devices on the bottom thing. Out of them, most of them are in a preclinical stage or early first-in-man trials. So we are optimistic about it, but not much more to kind of discuss in detail here. I'm going to end by presenting you a case. This is a case of a 42-year-old woman who had a new diagnosis of heart failure, and she already had CKD, progressively worsening, stage 5, not yet on hemodialysis, and came to us with repeat heart failure hospitalizations. The GDMT or guideline-driven medical therapy for heart failure was limited by persistent hyperkalemia, which is not uncommon. On presentation, her LV function or LV ejection fraction, which is a marker of systolic function, was 22%. She was class 3B because of a recent hospitalization. And we did a cardiopulmonary stress test. Her peak oxygen consumption was 8, which is very low. Under 12 is what we consider for cardiac transplant, and a high ventilatory slope. She was, because of this, between end-stage renal disease and end-stage heart failure, we referred her for dual organ transplant. But due to her insurance, she was deemed to be a non-candidate for organ transplant. Pretty young patient, And now all the limitations with hyperkalemia, end-stage renal disease, some of the things we heard about. So this is where we work with our nephrologists, our nephrology partners, and we collaboratively worked with them in finding a medium ground. And we instituted therapies such as SGLT2, MRAs, and ARNIs. She was started on dialysis, so which took care of some of those electrolyte perturbances. This collaboration resulted in substantial results. I just recently saw her. She has improved LV function, improved quality of life, not been in the hospital in the last 6 to 8 months, and NYHA class 2. And we are hoping to repeat her VO2 to see where her VO2 stands. Again, a great example of collaboration between specialties to improve the care of our patients and outcomes. So with this, I'm going to summarize by saying there have been major advances in pharmacological therapies, mechanical support devices, and cardiac transplant. These have resulted in gains in cardiovascular outcomes and improvement in renal outcomes as well. There are multiple new devices, both in the cardiovascular space and the cardio-renal space. Still in the early phases, first in man phase, but they look promising. However, we have a lot of challenges, and challenges include equitable distribution of these therapies, making sure all the patients who need them get them, whether it be insurance, whether it be awareness, whether it be collaboration between different groups. This is something I think the implementation science part of which, as the previous speaker mentioned, is where a lot of focus is going to be, which have to be in parallel to those developments. With this, I thank you for your attention and happy to send it back to you. Thanks.
Thank you so much, Dr. Panjrath, for a great presentation. And collaboration, like you said, is key in us moving forward with innovation. We'd now like to turn our attention to Dr. Paul Ridker, Director of the Center of Cardiovascular Disease Prevention, a translational research unit at Brigham and Women's Hospital. As a cardiovascular medicine specialist, he is also the Eugene Braunwald Professor of Medicine at Harvard School of Medicine. Dr. Ridker's primary research focus has involved inflammatory mediators of heart disease and the molecular genetic epidemiology of homeostasis and thrombosis, with particular interest in biomarkers for coronary disease, predictive medicine, and the underlying causes and preventions of atherosclerotic disease. Let's turn our attention to the monitors to hear remarks from Dr. Ridker.
Well, thank you, Sharron. It's a real pleasure to be here with the American Association of Kidney Patients and George Washington University. I'm very pleased to be able to join you to give this talk about interactions between cardiovascular disease and chronic kidney disease, and my particular area of expertise, which has to do with inflammation. So what I'm going to try to do in the next 15 to 20 minutes is take you through a story about inflammation and residual risk, and in particular take you through the implications for therapy, both with current drugs, such as colchicine, and future drugs like interleukin-6 inhibitors. These are my conflicts of interest. I'm a cardiologist, so I don't really see kidney patients on a regular basis, but obviously a lot of my patients have chronic kidney disease. I am, however, someone very interested in atherosclerotic disease and inflammation, and my research group has, for the last 30 years, really focused on one fundamental question, which is seen here. Can targeted anti-cytokine therapy reduce cardiovascular event rates, and for this evening, improve renal function? So you see on the left, serious atherosclerosis of the descending aorta, but you also see a patient with bad rheumatoid arthritis, and you see a kidney in postmortem. That's because these three disorders all share a commonality of underlying innate immune dysfunction. On the right-hand side, you see a cartoon, really, of the canonical NLRP3 inflammasome pathway of innate immunity, which ultimately leads to upregulation of the cytokines interleukin-18 and interleukin-6 through the IL-1 beta signaling pathway. IL-6 itself goes to the liver, puts out our biomarker of inflammation, the high-sensitivity CRP, and I'll take you through very briefly some of the therapies that we now know impacts upon this pathway and can improve outcomes for our patients. Back in 2016, I wrote this editorial for the European Heart Journal where we coined a new term, what we call residual inflammatory risk. This was addressing the obverse or the backside of the atherosclerosis prevention coin. Most cardiologists and general internists have used the term residual cholesterol risk for some time. As a cardiologist, my clinic is largely filled with atherosclerosis patients, most of whom have elevated levels of LDL cholesterol and elevated levels of high-sensitivity CRP, our biomarker of inflammation. Traditionally, we've thought about the left-hand side of this, residual cholesterol risk, a patient in whom I've lowered the LDL cholesterol with a statin, but I might want to take it even lower. The right-hand side of this is what I'm going to talk about this evening, residual inflammatory risk, where the LDL cholesterol is very well controlled on that high-intensity statin, but the CRP remains elevated. And in 2023, unlike in 2016, we now know that lower is better on both sides of this equation. You're very familiar with the lower is better data for LDL lowering. I'll take you through the lower is better data for inflammation inhibition. I want to challenge you at this meeting, 2 questions. What is the relative importance of inflammation and cholesterol as determinants of residual cardiovascular risk after you started them on a statin, because that's good medical care? And what are the anticipated benefits of adjunctive lipid lowering and adjunctive inflammation inhibition, again, after starting a statin? We just published these data in The Lancet about a month ago. It's 31,245 contemporary statin-treated patients, and as you might imagine, quite a few have chronic kidney disease, from 3 major clinical trials. The prominent trial that my group ran, the REDUCE-IT trial, and the STRENGTH trial. And in each case, we asked a very simple question. What predicts risk, the high-sensitivity CRP or the LDL cholesterol? If you just focus on the meta-analysis on the right-hand side, it's pretty clear that for the endpoint of cardiovascular death, the very thing your patients with CKD and my patients with cardiovascular disease fear the most, high-sensitivity CRP is a very powerful predictor of a future death. LDL cholesterol, not so much. And that's the insight that's driving this whole field. We also published in that data looking at interactions between inflammation and hyperlipidemia. So let's start with the far left-hand side. That's a low CRP and a low LDL. That's low risk. That's what we would expect. On the far right-hand side is high CRP and high LDL, and that's the highest risk. So far, so good. But now let's look at the bar second in from the left. This is a low CRP, high LDL patient on a statin, and there's no risk. But second in from the right, a high CRP with a low LDL, patients who our guidelines are telling us are just fine, have very high risk. And a lot of those patients, as I'll show you in a minute, have chronic kidney disease. So the challenge from the cardiologist perspective is, what drug are we going to give after we've given a statin? And we certainly are under a lot of pressure to give some very expensive drugs, all of which, by the way, have been proven to lower risk. But again, if you look at these drugs, the PCSK9 inhibitors, 15% reduction. Our anti-inflammatory trial, CANTOS, using an IL-1 beta inhibitor, that's canakinumab, was a 17% reduction. But on the far right-hand side is colchicine, 0.5 milligrams, given once a day. In the COLCOT trial of patients with recent myocardial infarction, and then the LODOCO-2 trial of chronic atherosclerosis, 25 to 30% relative risk reductions. But very important for this audience is an asterisk on those 2 trials, because I'm not eager to give colchicine to patients with moderate or certainly severe chronic kidney disease. There's some history here. My research group has been involved in this arena for over 30 years, and we published a series of New England Journal papers quite a few years ago that are summarized here, that many different biomarkers of inflammation, high sensitivity CRP that you know about, but also serum amyloid A, another pentraxin, interleukin-6, the key signaling cytokine, as well as adhesion molecules like ICAM-1, all interact with lipids to predict risk. That's the data on the left. The data on the right were very important for clinical care. You're seeing survival curves for patients with increasing quintiles of HS-CRP as well as increasing quintiles of LDL cholesterol. They both predict risk, but they're independent of each other, and you can't predict A from B. So the only way to know is to actually measure both the lipids and the inflammation. Now, several years ago, we published a clinical trial that you may recall that was called JUPITER. This was a randomized trial of statin therapy among patients who would not normally have gotten a statin because the LDL level was already low in primary prevention, but their CRP was elevated. What I want to remind you is that these patients were given a high-intensity statin despite having a low LDL, and it's also the only clinical trial to ever show reduction in all-cause mortality. And we're talking here 45 to 50% reductions in event rates. And as you see on the right-hand side of the slide, patients who only had an elevation of HS-CRP, that was their only risk factor, they had a large benefit. So the question became, could we address inflammation directly? Because that JUPITER trial I just spoke about used a powerful lipid-lowering drug that also had anti-inflammatory properties. Well, we got there by going back to this NLRP3, I spoke about earlier. This is a simplified version where interleukin-1 is activated, upregulates IL-6, puts out the CRP from the liver, and this is the target we're going to go after in our new trials. Many of you are probably aware of the CANTOS trial that we also conducted. This is the canakinumab anti-inflammatory thrombosis outcome trial where we used a pure innate immune inhibitor. canakinumab, a monoclonal antibody that targets interleukin-1 beta. Ultimately, we randomized over 10,000 secondary prevention patients worldwide. I'll come back to the CKD data from this trial in a minute, to 3 different doses of canakinumab, basically low, middle, and high as compared to placebo. What you see in the lower left is the experimental outcome. Dose-dependent reductions in CRP, dose-dependent reductions in interleukin-6, but now, unlike Jupiter, no change whatsoever in LDL, HDL, triglycerides, or in blood pressure, or in hemoglobin A1C. So we've done one thing. We've hit interleukin-1 hard, which also lowers IL-6. And what you see on the right-hand side of the Kaplan-Meier survival curves, a 15 to 17% reduction in major adverse cardiovascular events, or MACE+, yet we did this with no change in cholesterol, no change in ApoB. And this is important for the cardiology community because this is a risk reduction as large as you get from a PCSK9 inhibitor where you take LDL cholesterol down to 25 or 30. But again, we only targeted inflammation. So this is proof of principle that lowering inflammation in our patients really does matter. So let's go back to that inflammasome structure, and I want to take you through 3 drugs. I've already talked about number 1, the interleukin-1 inhibitor canakinumab. Now I'm going to shift to the microtubule polymerization inhibitor colchicine, and then I'm going to end with some data about interleukin-6 inhibitors, and particularly a new drug called ziltivekimab. Now, colchicine is a drug that we as internists know from perhaps treating gout, perhaps treating pericarditis, and for our colleagues who work in certain parts of the world, perhaps treating familial Mediterranean fever. But colchicine has many anti-inflammatory effects, which largely have to do with neutrophil function, and because it blocks polymerization of large-scale proteins, inhibits that same inflammasome and, in fact, leads to a reduction in C-reactive protein. 2 major clinical trials have now been completed, both published in the New England Journal of Medicine. The COLCOT trial on the left, 4,745 patients who had a myocardial infarction within the last 30 days, and what's called the low-dose colchicine 2 or the LODOCO 2 trial, 5,522 patients with stable atherosclerosis. Both of these trials showed statistically significant reductions in hard cardiovascular outcomes, hazard ratio 0.77, hazard ratio 0.69. And I would point out again, these are roughly twice the magnitude of benefit we see by giving an adjunctive lipid-lowering drug on top of the statin, and all these patients were statin treated. Let's talk about chronic kidney disease. What you see in the lower right-hand corner in yellow is that when the GFR was below 60, we really saw no benefit here. And as I'll talk about in 1 minute, this drug is renally excreted and hepatically excreted. So while there's a lot of interest in adding colchicine to many atherosclerotic patients, it probably is not what we're going to do for your patients with severe CKD. What I also think is worth knowing, though, is this idea of inhibiting inflammation on a chronic basis. For my patients in clinic with atherosclerosis, you can start this drug at any time and get benefit. These are landmark data from the LODOCO 2 trial saying if you started the drug at year 1, year 2, year 3, or year 4, since the initial atherosclerotic event, it simply worked. That's good news for our patients. But colchicine metabolism is tricky. I have argued publicly not to prescribe colchicine in the setting of seriously impaired renal disease or seriously impaired hepatic function, because that's where the drug is metabolized. But for those patients who we are giving the drug to, we still have to be a little bit careful and discontinue the drug short term if the primary care physician, the general internist, has prescribed certain antifungals, fluconazole, ketoconazole, or clarithromycin. These drugs are strong CYP3A4 inhibitors and P-glycoprotein inhibitors. We just simply stop the colchicine for the 8 to 10 days the patients might be on the antifungal or the antibiotic. Well, all of you are very sophisticated about kidney function, and this is an interesting issue. In the United States, the colchicine dose we have is 0.6 milligrams, but the trial doses used in those global trials I just talked about is 0.5 milligrams. And it probably does matter, that 20% difference in dose on a chronic basis. What you see on the left is pharmacokinetic data that at 0.5 milligrams once a day, even with mild to moderate renal impairment, we see very few patients crossing the safe upper threshold limit for colchicine concentrations. But on the right-hand side at 0.6 given once a day, you can see at 50 and 70% reductions in renal function, we're getting some pretty large excursions above that line. So we're very hopeful that the United States will soon have a 0.5 milligram tablet. Now, we're trying to focus on chronic kidney disease for this meeting. And within CANTOS, we pre-specified that we look at patients with GFRs below 60 and above 60. You're well aware, obviously, that these patients will have higher absolute risk. You see that data on the left. But for the 1,192 patients who had moderate to severe CKD in CANTOS, the risk reduction with the IL-1 inhibitor was, if anything, even greater. Well, that's very exciting. That means if I can't give these patients colchicine, perhaps I can give them a targeted anti-inflammatory drug. So let me describe one other piece of information we discovered in our CANTOS trial of interleukin-1 inhibition, and that is that the robustness of the downstream inhibition of interleukin-6, that's the data on the right, and the consequent downstream inhibition of high-sensitivity CRP, the data on the left, were really the drivers of success. This is a responder analysis. It's asking the question, after a single dose of an IL-1 inhibitor, who benefited? And the answer was those who got the largest IL-6 reduction benefited by far the most. Well, that was a signal to us that maybe we want to target interleukin-6 itself. This is data that you're probably familiar with from the stability investigators. The x-axis is interleukin-6 concentration. The y-axis is the 1-year probability of a major cardiovascular event rate. And then you see 3 different levels of glomerular filtration rate going from effectively normal to moderate to reduced. It's the same issue. As renal function declines, IL-6 levels go up and risk goes up. Now, my friend and colleague Kathy Tuttle, very well known in your renal community, has described very similar data about inflammasome and interleukin-1, interleukin-6 function in the kidney. You see the data also on the right-hand side from the CRIC trial telling us that inflammation, just like in atherosclerosis, drives disease in renal failure. And you see the greatest predictor of future atherosclerotic risk in the setting of CKD is, again, interleukin-6. Well, we were very interested in that, and working with a small company in Waltham, Massachusetts called Corvidia, and ultimately with a very large company, Novo Nordisk, in Copenhagen, we worked to develop a novel interleukin-6 monoclonal antibody that targets the IL-6 ligand. And what we discovered was that we got very large reductions in downstream CRP. So in CANTOS, we had about a 45 or 50% reduction in CRP, but the larger reduction was the better outcome. Here, we're getting 85 to 90% reductions in CRP, and you can see that in the waterfall plots, so that all of our patients should now be in the range of responders. On that basis, we designed what you know as the ZEUS trial, and I want to thank the investigators at GW who are also participating in this trial, and you can enroll patients at GW if you wish. This is the ziltivekimab cardiovascular outcomes study, where ultimately we're going to randomize 6,200 patients on a global basis, all of whom have atherosclerotic cardiovascular disease, stage 3 to 4 chronic kidney disease, and we call residual inflammatory risk, a high sensitivity CRP greater than 2 milligrams per liter, despite being on all guideline-directed care, including statin therapy. Half the patients will get excellent care plus placebo. The other half will get the interleukin-6 inhibitor ziltivekimab. And we actually have 2 different outcomes here. The primary outcome is cardiovascular events, and I'm in charge of that part of this trial. But my nephrology colleague, Vlado Perkovic, is in charge of the renal half of this trial, because the second thing we're trying to understand is, can we slow the progression of renal disease? So let me try to summarize where we are today and where we're going. Number 1, as you're well aware, patients with chronic kidney disease have very high vascular risk, and statin therapy, while important to give, is less effective as the eGFR declines. So we're trying to find other therapies for our patients with chronic kidney disease that will protect the kidney, but also protect against atherosclerotic events. Number 2, inflammatory biomarkers like high sensitivity CRP and interleukin-6 predict renal disease progression in the same manner that they predict incident cardiovascular events. Number 3, IL-1 beta inhibition in the CANTOS trial demonstrated substantial benefits on cardiovascular risk reduction among those with chronic kidney disease. Number 4, colchicine is a highly effective anti-inflammatory therapy for atherosclerosis patients with preserved kidney function, but I don't think should be given to those with severe CKD and is renally excreted. And therefore, number 5, the ongoing ZEUS trial of ziltivekimab among patients with CRPs that are elevated, known atherosclerosis, and stage 3 to 4 chronic kidney disease will discern whether or not IL-6 inhibition will reduce cardiovascular event rates and will slow progression of renal disease. So Sharron, thank you again for the opportunity to join this wonderful meeting. And I think we're learning a great deal today about the relationships of chronic kidney disease, cardiovascular disease, and the inflammatory mechanisms that seem to drive both of these processes.
Thank you, Dr. Ridker, and to all of our guest speakers today. This was a very informative session.